I'm Dr. Mark Gold, and this is the Gold Standard. It's my pleasure to have here with me at the Gold Standard Dr. Alan Schatzberg, who is someone I've admired for many years. You'll hear more about that. But really, he's a gold standard expert in so many areas of psychiatry that I thought I should have him here just to save me on the number of guests I need to have. So again, thank you, Alan, for taking the time and joining us here at the Gold Standard.
Well, thanks, Mark, for inviting me. And it's always great to be with an old friend. So it's terrific.
Thanks so much. And, as I thought about this, I said, I have 4 children and only one's a psychiatrist. And who would I trust to train her in psychiatry? And, you'll remember, I'm so proud that Jessie graduated from Stanford and was able to spend that time with you during her residency.
Well, she was a great resident. She was one of my chiefs and on the inpatient service. And I would go up there regularly and do rounds with her and with the medical students and the residents. It was just a delight. And we're so happy and pleased that she's done so incredibly well post finishing at Stanford. She was a Yale medical student before that and had a great career there as well.
So I voted with my feet. So, looking at it like addiction people do, I voted for Stanford. And really, in my mind, you built that department. But I didn't know if I would go back memory lane. Since you were so important to me, I remember meeting you. And I remember meeting you because I was introduced to you by Jack Mendelson. I came to discuss the clonidine work, and you had just really, I think, had a faculty position. You may be just the assistant professor in early 80s, and I was really mostly a monkey researcher. And so Jack took me and Nancy out, and I spent a couple of days up there, and I kind of remember them telling me that you were going to be the chairman at Harvard.
I doubt that, but it is flattering. But it is interesting. Jack and Nancy were one great investigators. Nancy Mello was his wife, and she was an incredible primatologist. She just did brilliant work. He was a translational researcher, a psychiatrist in alcohol abuse, did a lot of work in neuroendocrinology. And that
Definitely.
really was a unifying kind of feature between ultimately your work with a lot of it with after clonidine, with beta endorphins and glucocorticoids, our work in glucocorticoids, and Jack was very interested in peptides as well. And so it was a fun time.
I think he was I don't know if he was the chief of drug and alcohol, but I think he was. He sent me a preprint of a paper he did on buprenorphine. So even though he was an alcohol investigator, he's really one of the pioneers in buprenorphine, thinking about it for treatment for opioid disorders.
Yeah, I mean, one of the folks he recruited was Roger Meyer.
Yep.
Who did a lot of the opioid work, and then Steve Mirren.
Steve Mirren, yeah.
Who also worked then for Roger and did a lot of the clinical work on their inpatient unit. So that was a very active group, both for opioid use disorder as well as for alcohol use disorder.
I kind of remember, came from New York. I went to NYU, went to Harvard for your training. Why didn't you go to Yale?
Well, I was lucky enough to get into Harvard, and Boston is a bigger city than New Haven.
Yeah, I agree completely. And you had the chance to work with a lot of pioneers. I mean, we just mentioned Jack and Nancy, but Joe Schildkraut. I mean, most people in my work on locus coeruleus, like Joe Schildkraut and measuring MHPG and understanding noradrenergic systems. I mean, you were right there at the cutting edge of kind of translational clinical psychiatry.
It's an interesting point. Now we talk about translational psychiatry or whatever, or translational research. The reality was that guys like Schildkraut were the original guys doing
Definitely.
translation research. They were measuring catecholamine excretion, often in urine, to kind of subtype the depressions to look at prediction of response or whatever. And I sort of cut my teeth working for Joe. Joe was a phenomenal investigator, brilliant. Came up with the catecholamine hypothesis. And he really kind of helped launch my career, and was a giant, really a giant
Definitely.
in the field.
Definitely. That's kind of so I shared this tradition with you because in my group we had George Henninger, who was trained by those guys, and Jim Moss, who in the collaborative study was the overall PI or co-PI. And so my monkey lab was Moss's lab, and my clinical rotations were Henninger. And Henninger said the thing he learned from Schildkraut's discipline was that the only thing that mattered in psychiatric diagnosis really was who were the lithium responders, or who were going, you know what I mean? Like he wanted a diagnosis of lithium responder or imipramine responder or like Haldol responder. He didn't like the clinical menu in
No,
the
these
DSM.
these guys were the initiators of biological predictors of response. I mean, you talk about personalized medicine.
Right.
That's where it started. And MHPG was a good predictor of the more noradrenergic agents, the nortriptylines, the imipramines, the desipramines. And a lot of that work came from Henninger, as you point out, Jim Moss, Schildkraut. They were all publishing at the same time and kind of replicating each other. It's very interesting. I think some of the strongest findings in biological psychiatry are that low catecholamine output predicts response to noradrenergic agents. The problem with the whole thing was we didn't really quite understand what to do with the people who had high catecholamine output. And there were people who poured out catecholamines, often also pouring out glucocorticoids. So they had high cortisol levels and high neurotransmitter of norepinephrine and metabolite levels. And those people we didn't really have a good beat on as to what they respond. At one point, people said, oh, they'll respond to amitriptyline. There was some data, but it wasn't really conclusive. Alan Rosenbaum out in the Mayo Clinic had some nice clinical data, but not control that lithium seemed to be a good drug for those people. So, which made sense, but we didn't have any control trial. And I think that really hurt the development of these markers. But having said that, 40 years later, 35 years later, we ain't better off. I got news for you. We don't have better markers than those.
Yeah, I mean, I think it's those guys were trying to change the field so we wouldn't have so much trial and error, and
Right.
that we could be like other branches of medicine and have diagnoses that were predictive.
Absolutely. Absolutely.
Well, so in thinking about your career, and I've had the morning to think about it. No, I obviously, because I text you all the time, and I want to thank you for that because you've continued to be a mentor and great help to me. And just even as even this week, my papers on ketamine relied on you in a way that probably most people wouldn't recognize. But I want to thank you for that.
Yeah, I'm delighted.
Well, I mean, I did put in there that you warned about ketamine. I don't know, 10 years ago. There's a Stanford press release where you have a bunch of really amazing quotes, and I love them because they're just crisp and original and to the point. And I tried my best in my piece on ketamine to say, I said, it's not like ketamine treats depression the way penicillin treats strep throat.
Yeah.
You can't, it's not like the automat where you go in and you say, I'll have ketamine, and somehow you're cured. I actually think people believe that.
Well, it's very interesting when you look at, and we do ketamine trials today, clearly they work in some people and it can be quite powerful. The response rates are not incredibly high, either for ketamine or for the enantiomer, the S-ketamine that's approved as Spravato as an intranasal. You're not getting huge response rates. You're getting response rates that you see kind of with adding atypical antipsychotics to antidepressants, around 35, 40%. But somehow, because it's a powerful drug and the experience is powerful, people have this notion that this aha medicine, if you will, is universally effective. That it's going to be effective at 100% and 90%. It's the same kind of thing with the psychedelics. But as we study them, as we study the psychedelics as well as ketamine, the response rates go down. They don't stay high. When you're dealing with larger populations, mixed populations, or whatever, your response rates come down, and the response rates are somewhere around 40%. Helpful, no doubt, but it is not a panacea.
Well, I mean, it gets back to the original point, which is it would be much better if we identified ketamine responders somehow, rather than have a diagnosis that means you can treat almost anybody with anything. Like some of your quotes were, you said that ketamine worked mostly, I kind of put this in my memory, I could be wrong, that it had a lot to do with hope.
There is no question that there is the sense of hope is extremely important to people. I worry, though, that if people aren't met with a good response, the disappointment can be quite devastating. So, it is an issue. And I was just talking with another investigator who's, actually Jerry Sanacora,
Oh,
who
yeah.
really, from Yale, who really has, I think, settled down on the notion that the expectation bias is extremely important, with
Yeah, and just
drugs.
yesterday, I agree. I mean, I spoke to him for the last article on ketamine, and he said he's in favor of a national registry to protect patients.
I think it's I think we need a little bit better control over the situation. We see more and more uh, adverse use, adverse effects. If you look historically around the world, where you've had ad libitum access to use, in China, they had hundreds of thousands of ketamine addicts snorting it. You had issues in Australia when doctors were giving out intramuscular ketamine for home use. Yeah, people can get into trouble, and I worry about physicians who prescribe oral ketamine to be compounded at a specialty pharmacy. Whether in fact we are starting to get into people misusing it, overusing it,
Definitely,
becoming addicted to it. It is addicting.
definitely.
It's less addicting than many opioids, but it is addicting. And I think just having this general use is a real problem. And we have this loophole in our law because, as you've written and whatever, about off-label use, right? Matthew
Definitely.
Perry getting it as an off-label use. And in your article, as you very nicely pointed out, the blood levels attained, which are about, I don't know, 2,000 nanograms per ml, I think, are not attainable, days after having ketamine given intravenously. So you have to be taking a bunch of it. And as it came out and reported in the press, because there was, I think, a conviction of one of his staff that they were administering intramuscular injections of ketamine, beyond what he was getting from his psychiatrist in terms of an IV infusions periodically. I think I think there has to be some boundaries on the use of this, and we have the boundaries with the intranasal
Definitely.
Spravato because there's a REMS and there is a very clear prescribing twice a week for a month, once a week for a month. I think that that has in fact protected the community. I think without having that, or one having a very spread out kind of protocol, as well as having limited access. So you're not just giving people ad libitum home use access. They made it a much safer drug. And I think if that continues, that'll be safer. I think this home access oral ketamine tranches or whatever, that's problematic. I think it's problematic, and we're seeing more and more use.
Well, I agree. You warned about it 10 years ago, I think, about that time.
Yeah.
It basic science is pretty clear. But I think you added to that the whole field by being able to show not only the reversibility with naltrexone. That was a really important paper to me, but most recently on the meta-analysis in the small incremental benefit. So if you have a small incremental benefit and you have addiction liability, you should keep that in mind before you go forward.
Yeah, I think the risk benefit ratio kind of does shift. I think the whole story with the naltrexone, and we kind of communicated this, and you used my quote in your Psychology Today article. It was interesting because it is nice to be replicated, right?
Yes, exactly. I feel the same way. It's like you don't care that it's 10 years.
I'll take it anyway as long as I'm walking.
That's what I like. That happens to me sometimes. I'll go like, sometimes, I remember Floyd Bloom, who was an editor at Science and used to send me articles, and we had a lot in common. And one time he said to me, thanks for your work. And I said, yeah, but all 10 articles you sent me, I rejected. And he said, well, that's why I send them to you. And in your case is the same. You're not influenced by the mob here. And you could stand back and say, well, let's look at this with clear vision. Think about the psychopharmacology. And the naltrexone thing was one of your articles that I wish I did.
Well, that's very kind. I'm very proud of that study. I'm delighted that last week Luke Jellin at the King's at the Maudsley kind of replicated and extended it with some very elegant imaging work and published in Nature Medicine. So I think, we had Jerry Sanacora and I had done a perspectives piece in neuropsychopharmacology about the mechanism of action, and in it, I said. To me, it looks like it's an opioid because no other NMDA antagonist gives you that kind of response. They've been studied. Memantine has been studied incredibly multiple times at the NIMH, by the manufacturers or whatever. So it just didn't make sense. And, but there was some binding to opioids and that had been reported. But when you ask people, they say, well, it binds, but it doesn't do anything. Well, that doesn't make much sense. I mean, and the binding to opioid receptors, mu opioid receptors, is about the same as it is to the NMDA receptor. So we kind of said, hey, this is a testable. You can do an experiment. Take depressed people, give them an intravenous infusion of ketamine, give them two. Both times you will give them the infusion, but one time before the ketamine, you'll give them naltrexone, which is the antagonist for the opioid receptor, used to reverse overdoses, used to sustain life, used to treat opioid or alcohol use disorder. And the other time you give them placebo and you cross them over. And we did it, and what we showed very nicely is these people had these aha moments of, oh, I feel fantastic or whatever, regardless of whether they got it first or second, the naltrexone. When they got the naltrexone, they didn't have that aha moment, you know. And overall, the groups that had, when they got naltrexone, responded significantly less than they did when they got placebo. And the effect size was around zero point 0.7. Luke Gellin just reported almost the exact effect size, 0.6. So there have now in between, Mark, there have been about 10 or 11 preclinical studies using various models for the behavioral effect, for swim test, tail suspension, etc. And all of them except one, have shown that naltrexone or naloxone blocks the behavioral effect of ketamine in the rodents. And a couple of them have shown that ketamine is reinforcing. The animals will work for it. And if you look at the two enantiomers, the S-ketamine, proved for depression, is much more reinforcing than is the R-ketamine, which already has, in one study, been shown not to be a very good antidepressant.
Right.
So I think the opioids play a role. What is still open for, there are a number of things that are still open for debate. And one is, there's a very nice study from Chris Pittenger at Yale, at your old haunts, and where he showed very nicely that if you gave naltrexone to the rodent, you block the behavioral effect of the ketamine. But you could block the behavioral effect of the ketamine by giving the animal an antibody to beta endorphin. So if you knocked out the endorphin release, you also got the same blockade of the positive effect. And it is possible that what we're seeing with ketamine is this release of iatrogenically releasing beta endorphin naturally, which gives you that very positive response or whatever. So that is possible. Jerry and I have talked about doing a paper to kind of outline how one could try to study this to kind of get a sense. But it brings in this hope issue of right. that Jerry raises. It brings in kind of the question of placebo response. But this positive kind of psychological response maybe is biological, right? Mm-hmm. Without, I mean, the
placebo response itself might be endorphin.
I think so. It is probably. And it's something that there's a nice paper Mauricio Fava has done, arguing that we probably should look at do antidepressants and do antidepressants and placebo, and then do the whatever the antidepressant is, giving naltrexone. Because then you could probably ferret out what is the positive, expectation bias. But I think that aspect will be advanced by having demonstrated naltrexone blocks the ketamine thing. We still need to figure out exactly. Ketamine still does bind weakly to the mu opioid receptor. It's micromolar. That is probably of some significance. And hope is not all of it, as I said to Jerry recently at a meeting, because the animals don't have any hope, right? They don't know what they're getting. They don't know what you're doing to them, and they don't have that prefrontal cortex development. And they show the same blockade of behavioral behavior. So I think, there'll be further work out there.
Sure.
We have another paper we've just presented, but it's not yet published. But we presented this at SOBP, and this is, I don't know if I sent you this, Mark, but there was a study about 4 or 5 years ago by a fellow named Yovel in Israel. They took hospitalized, suicidal, depressed patients in Tel Aviv, and half of them were borderline, half of them were major depression, and they randomized them to getting ultra low dose of buprenorphine, 0.2 to 0.8 milligrams per day, or placebo. And what they showed was that the buprenorphine at these tiny doses, separated from placebo at 2 weeks and at 4 weeks, the suicide ratings went from about 19 down to about 9 or 10. So the patients were still symptomatic, but the effect was statistically significant. And we just did a poster at Biological Psychiatry. What we did, and sponsored by the American Foundation for Suicide Prevention, we took outpatients who had suicidal ideation, histories of suicide attempts, etc., with major depression, and we gave them an intravenous infusion of ketamine, which drove down, to some extent, their depression, their suicidality. And then we randomized them to these low doses of buprenorphine and placebo. And at the end, the patients were not suicidal. They were in the range of being asymptomatic. So we were able, in fact, to show that buprenorphine in low doses, just as Yovel did, was better than placebo. But we could, in fact, get the patients unipolar depressions to be unsuicidal after 4 weeks. And so that would suggest, that buprenorphine may be acting in the same mechanism.
Same way. Yeah.
As ketamine.
Yeah, it's wonderful work. And I remember thinking about opioids in unipolar depression, and I couldn't really figure out how to use them without addicting everyone. Back then, we didn't have much choice.
Well, what we did is a couple of things that we did. Yovel said he brought the patients back a couple of weeks later. He didn't see any particular withdrawal or whatever. We actually formalized that. At the end of the 4 weeks, patients were either on buprenorphine or placebo. We didn't know. And we stopped whatever they were on. And we followed them for 2 weeks. The patients who were on buprenorphine actually showed an increase, a small increase in depression and suicidality.
Oh.
And then the following week, when they're further away, it came back down. They showed there was no positive endorsements on the OAS scale or the SOAS scale. So they weren't in formal withdrawal, but they had this discontinuation-related kind of worsening of their symptoms. In the placebo group, there was no change. So what we're seeing is at 4 weeks, even though these are, we're seeing that the patients, maybe they need to be treated further. It's possible.
Mm-hmm.
Or maybe they need to be tapered. But it also suggests that the buprenorphine is, in fact, having a positive effect. Because away at 4 weeks, you see some worsening.
I think so. That makes sense to me, too. And we did some animal work on post-fentanyl self-administration anhedonia in animals, and buprenorphine was very effective in that way. And also, our experience with people who are on opioid agonists long-term is that almost all of them end up to be treated for depression. So you do end up, anhedonia is the main consequence of opioid self-administration or administration in a clinic. Let me move on. So just on the naltrexone and the effects, the ketamine effects, was Nolan Williams on that paper?
Yeah, he's the first author. He was a mentee. And and Boris Heifetz, who's an anesthesiologist, neuroscientist at Stanford, they were the first two authors.
So I bring up Nolan just because, you built the department at Stanford and you got a career as a mentor. And Nolan comes from MUSC. He's basically just a TMS guy. You trained him. Like, I thought that was a great paper for him to be on. And then his whole Saint progress was a benefit of his MUSC background, his personal experience, and your mentorship. And then he's got his Ibogaine, which really, I think, he's had, you developed 3 big areas for him in a very short time.
Well, I certainly, the naltrexone ketamine thing was something that, we had been talking about for a decade. Maybe a little less, but we've been talking about it. And then he joined us or whatever, and it was great that he could lead that study. The Saint is, I was a collaborator, and he was my mentor there, teaching me.
Well, I
about
mean,
TMS, you
yeah,
know.
I mean, he came from the best program. We used to send our residents to be trained there. I mean,
Well, Mark George is
yeah,
certainly one of the founders in the field, right? I mean, he's just really brought RTMS, to psychiatry, and
only a neurologist could do it.
yeah. Well, he's a psychiatrist too, but he went when he was somewhere in his training. He went to England because they were using TMS for spinal cord stuff or whatever, and then he got the idea of, hey, we could do this, for depression, and so very, very clever, and he continues to train great people. He's got Joe
Definitely.
Taylor is up at Harvard now doing great stuff, and there are a lot of folks that he's really developed, and he's really been a real great generator of talent for the field.
And so I've gone, so you have the naltrexone, you have, I know Nolan stuff too, thanks to you, but also because of Mark. And then you have the Ibogaine, which was really interesting for me because when I was the chair at Florida, and even before that, when I was a neuroscience professor at the University of Miami, was Deb Mash, who did the original work. And she had even set up her own kind of rehab in an island, I think, for use of it in opioid use disorders.
It's, I am not, I've talked a lot to Nolan, and I am sort of involved in some of the stuff he's doing now. He got involved with that because Rob Malenka uh,
Oh,
had been talking to the people at Vets and whatever who have been sending folks,
to
sending
Mexico.
warriors down to Mexico. And I think there was a thought that they needed to have some formal evaluation of these folks pre and post to see if there's a change. I've talked to a bunch of these folks. It's remarkable when that some of these people have just changed their lives. And there are now a number of advocates out there, some of them politicians, very successful ones who have had traumatic brain injuries, and who have got great relief from Ibogaine. And so that you've got these two uses that are out there, right? It's the use
Medtron.
for one for traumatic brain injury, but it's the other on opioid use disorder, where, as we all know, the craving post stopping is enormous and unbelievable and difficult to control. And the responses there for the Ibogaine are dramatic as well. I think, the questions that one has is obviously going to be difficult to do controlled trials, but, there are ways of doing it. You can do at least dose response or whatever. But I think having some uh, imaging output, where there seems to be really structural changes, is helpful. I think that's what Nolan showed in the Nature Medicine paper. I think the other thing that is intriguing is somewhere there will now need to be studies to show that combining the ibogaine with magnesium sulfate or some magnesium preparation does in fact protect the patients against the cardiac arrhythmias. That's always been, for the last 30 years or whatever, that's always been the question is, can you do this safely? It does look like when that some of these clinics in Mexico do not, where they're using the mag sulfate intravenously or some form of magnesium, they seem to be not having the cardiovascular problems that I think were seen early in the development and early in the study. So hopefully, if this really works, and this could be compared or paired, if you will, with preclinical studies, right? I mean, in preclinical toxicology can really kind of demonstrate that there isn't an effect on cardiac function, looking at HERG and whatever, So I think that problem is solvable, most likely. It's just the way it's going. But that is going to be the big, I think, hurdle, as well as, how do you blind the studies, et cetera.
Yeah. So like I don't know if you saw this or paid attention to psilocybin work, but Josh Siegel had that Nature paper that the Times covered on page 1, and they used Ritalin as the active control. And I asked them about that, but what do you think about controlling?
I think there are a couple of things that are important to keep in mind. One is to show, let's say, an antidepressant effect, you don't have to necessarily beat placebo, right? You could beat treatment,
Standard treatment.
It would require larger studies or whatever. And so that is one way. Another way is to have a better placebo. We've argued, going back to the ketamine, that the ketamine naltrexone story gives you actually a pretty good placebo, right? It cuts the drug response. It cuts certainly that aha kind of response. So for ketamine and for related drugs, why not have a cell of ketamine plus naltrexone?
Right, that's a good idea.
Yeah. We haven't really kind of gotten anybody to bite on it, but that's what I think that's what I would do. I would use ketamine naltrexone. So that's one. I think Ritalin, perfectly okay. It certainly has.
Because if you think about it, like Nora used Ritalin for cocaine control and PET imaging, and Josh Siegel, his psilocybin mechanism of action paper was greatly benefited by Ritalin. But I do think the patients, he had the advantage of using normals who had no drug experience. For drug using patients, they're a bioassay, and they can actually, they can pretty well tell what they're taking.
Yeah, and I think a depressed patient, first of all, a lot of them will have been exposed to Ritalin anyway, right? Because we use it for augmentation. And Ritalin does not, you'd have to give an awful lot to
IV, yeah.
to get people to hallucinate or whatever. So,
Oh, right, yeah.
So I think you can get the positive mood potentially. That there is a kind of a stimulant effect, for a lot of these drugs beyond other effects. But I think we have to kind of dissociate the people. One of the things that in our ketamine naltrexone study is the naltrexone did not block dissociation. Those people were dissociated just like everyone else. They just didn't have the antidepressant effect. So that I think is important. And anyway, but I think there are going to be some clever ways of trying to blind. And I would think that naltrexone could be very useful because at least you can block the antidepressant effect.
Mm-hmm. So that's really a great conversation and very helpful. I'm sure someone who's listening that'll be new to them, and that's a good thing. You've tried throughout your career, I think, to separate out psychotic depression.
Yeah.
And also worked on glucocorticoid related treatments. Could you just bring us up to date to where you are in that?
Well, so we going back to the 80s, so when you're around long enough, you have this pre-PubMed kind of, right? It's one thing that's so interesting when you review grants and there's something you've done some good work on or whatever in the 80s, and never get cited because the PubMed.
I feel the same. I feel the same way. I spent 10 years of my life proving that cocaine was addicting because it wasn't the DSM-1, 2, or 3, and I had to actually do the work. But the dopamine hypothesis paper was 84. No one ever references that.
It's unbelievable, isn't it?
Yeah.
So, we got into this because we had shown that and at the same time, actually, around the same year in the 83, in the American Journal, we reported that these high rates of non-suppression seen in depression were largely due to people who had delusions or psychotic. Those were the hypercortisolemic depressives. Charlie Nemiroff and Dwight Evans replicated that a few months later, reported the same thing in the same journal, American Journal. And we eventually argued that, we probably could treat these people by giving them a glucocorticoid receptor antagonist. And the mifepristone, which is RU46, which is the French abortive fashion drug, uh, we showed in a small number of people that, in fact, that these people had rapid responses. We did that after Stephen Lambriers, who was the rector in Rotterdam of the university, and was a very distinguished endocrinologist, had reported that in Cushing's, so these are people with pituitary tumors, those people are hypercortisolemic, and Cushing's, people need to realize it has a mortality rate of 5 years of 50%. It's a deadly disorder. And he had these terminal people who had become psychotic. And he gave them mifepristone, which is the French abortion pill because it's a progesterone antagonist, but it's also a cortisol antagonist because they have high homology and the receptors have high homology. And so we said we could develop it, and we, in fact, showed that it seemed to work pretty well. What happened then is that, we had founded a company, and the company, so I still have some involvement with the company in terms of stock. I don't do anything with them otherwise, but the company tried to develop mifepristone as a rapid treatment for psychotic depression and had some response. But what happened was, what we noticed was that the patients really needed to have a much higher dose because they needed to have a much higher blood level of drug to get enough into the brain to block the cortisol. And don't forget, when you give a GR antagonist to even a normal person, cortisol goes up because it's blocking the feedback to the pituitary, and the pituitary says, gee, I don't have cortisol. I got to make more cortisol. So when you do that, you have even more antagonists. And so we had studies that showed if you could use the blood level, you got very nice separation from placebo. But the FDA wasn't particularly interested in approving a drug that had to have a blood level with it because of post, what happens? These are just saying that people took the drug. Well, that wasn't the case because these were inpatient studies. We gave the drug, every day, and monitored the drug. So now what happened was we stopped doing it until we had a better glucocorticoid antagonist. The company has gone on to develop the drug for Cushing's, where it's marketed. For refractory Cushing's that doesn't respond to surgery. And what is very interesting, Mark, is apropos of old literature, the company has now shown that refractory diabetics who are not responding, to typical treatment, 30% of them are actually hypercortisolemic. They have failure to suppress the axis when you give them dexamethasone. And the drug for Cushing's, mifepristone, is really approved for the diabetes of Cushing's. And now the company has shown that in a double-blind study that when you give refractory diabetics mifepristone, you drop their hemoglobin A1C about 1.5 units. So it's staggeringly high. And so now endocrinologists are starting to use the drug for diabetes. I pointed out to folks in the company that in 1980, in the mid 80s, Jim Hudson and Margot Hudson, who were a couple then, she was an endocrinologist at Joslin, which is the main diabetes place for Harvard, showed that people getting admitted for refractory diabetes had about a 30% non-suppression rate. We just had totally forgotten about the
Forgotten it.
paper. And it was basically the same kind of. So here you go. This is this stuff but it shows you two things I think are important. One is we need to go back. And a lot of stuff was very, very well done. And if it's very well done, it often works out if you wait enough to get a replication. But it also points out that we really need to go back. There's a lot of very good observations that were done 40 years ago. And our whole point, if you really think about this, and apropos of your question, was to say hypercortisolism is not an epiphenomenon of depression.
Right.
Hypercortisolism causes other things. It causes insulin resistance. It causes psychosis. High steroid levels, Cushing patients are often psychotic. It causes, diabetes. It will cause all sorts of other disorders, including depression, types of depression. And the finding of high cortisol in psychotic depression has had three big meta-analyses published every decade and continues to be a finding. It wasn't just, a fluke finding. Again,
No.
put stuff out there, do it well. This is what I tell young people. Be creative, do it well. If it's done well, it will hold up.
Yeah, well, that certainly worked out for you. I mean, you look at your career, you did it at Stanford, like I said. You were the chairman. I guess you left Harvard for Stanford. That worked out. You built Stanford. You were the chair till 2010. You started the Mood Disorders Center at Stanford. You were the pioneering person in the department, really, in biological psychiatry. I counted well over, when I went to the Google Scholar page, over 700 papers, an H-index over 100. A lot of the thing since I hadn't been invited to write a chapter in the Schatzberg Manual of Clinical Psychopharmacology, I didn't realize you had a ninth edition. Do you have more than the ninth edition? You're 10th. You're the 10th.
We don't have any outside writers. Chuck DiBattista and I, we started with Jonathan Cole, who was a great mentor.
Oh yeah.
And that book is written, but the textbook with Charlie is edited. So we have.
Oh, that's another one. So how many editions do you have of that? 6 or 5?
Six.
Six. So that's also widely read. These are really good projects. I only could manage a second edition myself of my food and addiction book. And even in the addiction medicine textbook, the ASAM textbook, in the first edition, I wrote 7 chapters. But in the last edition, I'm down to 1, which probably means there are plenty of other experts and I was way over my head. But, your 2 textbooks are great. Thank you, sir.
Ahead of your time.
Well, your textbooks just have stood the time test yourself. And the fact that you update them is remarkable. I actually think when I came to Harvard with you guys, I got to meet a nephrologist who started Up to Date. And so Bert Rose asked me to be the first editor with Mark Aronson of Up to Date, which was a CD-ROM. And so that was the only, I could stand that project, and he was wonderful for 10 years. Like, the idea of continuously updating is just so tediously, it's a nightmare for someone like me.
Well, the good thing is for us, it's periodic. So so we drop everything every 4 or 5 years to come up with.
It's a great contribution. And, I listed because I'll do it at the end. You were the president of the American College of Neuropsychopharmacology. You were also the president of Society for Biological Psychiatry and also the president of the American Psychiatric Association. So to me, I couldn't think of anyone that was president of all 3 other than you.
Well, that's very kind. So
is it true?
the president of ACMP and the APA,
I could think of somebody there.
there are a couple. There's Al Friedman, Daniel X. Friedman, myself, Maria
Yeah.
Kondo. Um,
But if you throw in the third,
the third, I think that becomes, I don't know if anybody's done that.
that's good. That's why I had that. And then you were elected to the National Academy of Medicine. I think that's great. But all in all, I don't know how you have time to be an original thinker and do all this service. I used to say to my Yale mentors that I didn't like going to scientific meetings because I would listen to the talks and they would give me bad ideas. It sounds silly, but I would pay so much attention and I would go like off on tangents that just wasn't helpful for me.
I think that what is very important, I try to tell this to young people, is maintain your curiosity and try to be creative. If you're going to do a piece of work, if it's just a small extension, while it could be important, it's not going to sustain you in terms of your interests. So and it will have less of an impact. So you really people need to think a little bit more out of the box. It's extremely important.
So I just really wanted to take the last minute to thank you for taking some time out of your busy schedule to reminisce with me over the last 40 or 50 years, whether you're on like your remarkable contributions to psychiatry and psychopharmacology. You've won all kinds of awards. I won't list them, but did I notice that you had an honorary degree from the University of Vienna?
I did. And, my
I know
favorite.
Gabriel Fisher, and I also the dean of the School of Medicine. I was his guest because he was trained at the University of Florida, Marcus Mueller.
Oh yeah. No, my father and his two brothers were graduates of the University of Vienna Medical School. My parents came to this country in January of 1940. And the folks in Vienna, working with Hans Steiner, who was a Viennese and was our head of our child training program, with Siegfried Casper, decided that they would give me an honorary degree, with the idea being that maybe I might have been the chair there if the family hadn't had to flee Hitler. So it was very nice of them to do that. So.
Well, when I went there with Marcus, and I'm sure this is beyond the scope of the gold standard, thank you, but I went there, they have a statue to all of the Jewish doctors.
Yes, absolutely. The rector, the guy, the fellow who was the dean the president or the dean had in fact established that, and he had put a sculpture,
Yes.
memorial next to it. And they had all the doctors who, in fact, were on the faculty, many of whom succumbed, but many of them left. And there were about 175 of them. Today, the last I looked, there were about half a dozen Jewish faculty at the University of Vienna. Medical.
Well, I just, I could have talked about all of your other awards, but to me, that was remarkable, and we're glad that your family made it, and you made it to the United States, and you made it so quickly to Harvard, and helped psychiatry become what it is today.
Mark, I really appreciate the invite and the opportunity to do this, and I look forward to doing it again.